The initial management of this patient with iodine-refractory PTC, tall cell variant, was active surveillance. It was found basically in her initial workup and treatment that she had distant metastases that did not take up radioactive iodine, despite the treatment dose of radioactive iodine that she had. The CAT scan of the chest showed a number of small lung nodules. She was entirely asymptomatic. And I think one thing that's important to know is what is the pace of the disease? Therefore, she did have a repeat CT scan 3 months later. I think that active surveillance so that you understand the pace of the disease is a very reasonable approach for patients that have relatively low burden asymptomatic metastatic disease. She did indeed, however, at that 3-month time interval have disease progression, and therefore she was started on lenvatinib. Deciding to proceed with treatment rather than ongoing active surveillance is a judgment call that's not always easy to make. However, it's a very important part of the decision-making process for the initial approach to treatment for iodine-refractory disease that's progressive. In terms of drugs that are available for these patients in the United States, we have 2 multi-kinase inhibitors that are approved by the FDA. The first drug that was approved is sorafenib, and that was approved on the basis of the DECISION trial, which was a randomized phase 3 trial comparing sorafenib versus placebo with a primary endpoint of progression-free survival. The second drug that was approved is lenvatinib. Lenvatinib was approved on the basis of another randomized phase 3 trial dubbed SELECT, in which patients with iodine-refractory disease that was progressive within the 14 months prior to study entry were randomized to lenvatinib versus placebo. In both trials, when patients experienced disease progression, the patient was, randomization was uncovered, I guess. Unblinded is the word I was trying to think of. And patients that were found to have been on placebo were then offered crossover therapy with sorafenib in the DECISION trial and lenvatinib in the SELECT trial. So how do you decide which to use first? We have 2 FDA-approved drugs. As I mentioned, sorafenib was approved first, and now lenvatinib is also approved. The way that I think about this is that we don't have a head-to-head comparison. I don't think that we're going to have a head-to-head comparison of the 2 drugs anytime soon, and so it's a judgment call. In general, they're similar drugs. They're both multi-kinase inhibitors. They both inhibit the VEGFR pathway as well as multiple other kinases. Both drugs have similar side effect profiles that we can talk about a little bit more. I can't use the mechanism of action or the side effect profile so much to make the decision. So I look at the activity and efficacy data that we have available from the 2 trials. In the DECISION trial, the overall response rate with sorafenib in patients who were randomized to sorafenib was 12%. And the progression-free survival in that patient population was 11 months. Whereas in the SELECT trial with lenvatinib, the overall response rate is 65%, and the progression-free survival on the lenvatinib arm was 18 months. So when I'm comparing apples to oranges with these 2 different phase 3 trials, in general, the data do seem stronger for lenvatinib having a better efficacy. And so that's my go-to first drug for most patients with iodine-refractory differentiated thyroid cancer.